Assalamu alaikum. This is lecture 4 about carbohydrate metabolism and related disorders, to continue what we have started earlier in lectures of carbohydrate metabolism and related disorders. First of all, we will review some conditions associated with insulin resistance. As you know, type 2 diabetes is one of the important types of carbohydrate disorders associated with insulin resistance. Additionally, other conditions including metabolic syndrome and polycystic ovarian syndrome, which are the most commonly associated with insulin resistance as the major pathological mechanism. In metabolic syndrome, which is also known as syndrome X or reverse syndrome, it is closely linked to development of resistance state of insulin. It can be defined by the presence any three or more of the following features. First, abdominal obesity by measuring waist circumference for males exceeding 40 inches, for females exceeding 35 inches. Second, fasting plasma triglyceride more than 150 mg per deciliter. 3. Fasting plasma HDL less than 1 millimole per liter in males and less than 1.3 millimole per liter for females. 4. Blood pressure exceeding 130/85 millimeter mercury. 5. Fasting blood glucose level more than 100 mg per deciliter. In these conditions, where the plasma insulin level is elevated, the condition is hyperinsulinemia, could result in several metabolic complications. These can be detected in cases, in addition to type 2 diabetes, as we said earlier, metabolic syndrome and polycystic ovarian syndrome, also cases of fatty liver, raised fibrinogen and plasminogen activator inhibitor 1, renal sodium retention, hyperuricemia, and development of or formation of dense LDL particles, which enhance atherosclerosis development in these conditions. Now we will consider diabetes mellitus as the commonest type of metabolic disorders of carbohydrate metabolism, which affect a large number of subjects in populations. The major metabolic abnormality associated with diabetes mellitus is hyperglycemia, where the plasma glucose level is exceeded the normal range, as we said earlier. If plasma glucose level exceeded 10 millimole per liter, in this condition we will have glucosuria because it will exceed the renal threshold. The high urinary glucose level will result in osmotic diuresis, and therefore it would be presented as polyuria. Meanwhile, the hyperglycemia resulted in hyperosmolality would cause cerebral cellular dehydration, which would be presented as thirst or polydipsia in those patients. The prolonged osmotic diuresis would result in excessive electrolyte loss with urine, which cause metabolic abnormalities as a result of the major characteristic abnormality in diabetes, which is hyperglycemia. Diabetic patients on insulin therapy may develop several phenomena, Among these important phenomena is down phenomena, which is physiological response for the elevation in blood glucose concentration in early morning prior to breakfast due to nocturnal spike in growth hormone concentration and in cortisol concentration that would result in increased hepatic gluconeogenesis, causes increase in glucose level. On the other hand, some diabetic patients would develop another condition known as nocturnal hypoglycemia that may evoke a rebound counter-regulatory hyperglycemia called Somogyi phenomena, where the patient blood glucose level, if it would be checked at earlier in the day, that's to say at 2 to 4 a.m. in the morning, we will find lowered plasma glucose level. This condition can be distinguished by measuring or monitoring plasma glucose level. Second type of abnormalities associated with diabetes is development of dyslipidemia, which is disturbance or disordered in lipid metabolism. As we know or previously discussed, that insulin is important not only in controlling carbohydrate metabolism but also in lipid metabolism. During lipolysis, which enhance the formation of non-esterified fatty acids concentration, this process is usually controlled by the activity of the enzyme lipoprotein lipase, which requires insulin for its optimal activity. This process would be disturbed, result in increased level of plasma non-esterified fatty acid concentration. Therefore, these free fatty acids normally would be converted either to acetyl-CoA or ketones or to be re-esterified to form endogenous triglycerides and to be then incorporated into very low density lipoprotein particles to be transferred through the circulation to the peripheral adipose tissues. Cases of insulin deficiency is very severe. There may be also, in addition to increased VLDL levels, also would be have increased in chylomicron level. The rate also of cholesterol synthesis would be also increased, result in increase in LDL level in plasma. Therefore, patients with diabetes could be presented with the following lipid profile: increased plasma triglycerides, increased total cholesterol level, and lowered HDL cholesterol concentration. Now we will talk about chronic complications associated with diabetes mellitus. The two types of diabetes mellitus, type 1 and 2 diabetic patients, are at high risk to develop important or serious chronic complications, could be generally categorized as either micro or macrovascular complications. The microvascular complications would involve the retina and the renal glomeruli and the peripheral nervous system. The microvascular complications diabetic patients affect a large number of patients, mainly could result in blindness in persons between the ages of 25 and 74 years. And also it is the leading cause for reaching the end-stage renal disease. On the other side, the macrovascular complications resulted from atherosclerotic macrovascular complications that would involve both the cardiac and vascular system. As a consequence, patients with diabetes would have high rate for development of myocardial infarction, which increased the mortality rate in diabetics, also associated with high rate of strokes and limb amputation. Several prospective clinical studies had found there is a strong relationship between hyperglycemia and the development of microvascular complications. Therefore, it is very important for diabetic patients to have a good control for their plasma glucose level by either dietotherapy or using their medication. On the other side, both hyperglycemia and insulin resistance appear to be considered as important factor for the development of the other complications, the macrovascular complications. According to previous and nowadays studies, several hypotheses had been developed to explain the wide range of development of complications of diabetes. By these, we consider the chronic complications. Among these hypotheses that had been considered, the cause or the pathogenic mechanism for the development of these complications include increased aldose reductase or the polyol pathway activity. Second, enhanced formation of advanced glycation end products. 3. Activation of protein kinase C. 4. Increased hexosamine pathway inflex activity. By these mechanisms, there would be overproduction of free radicals. Among these, the superoxide production by the mitochondrial electron transport chain would complicate the overall metabolic complications associated in those patients. Now, in clinical chemistry, how would a diabetic patient would monitor his condition, mainly to avoid prolonged and excessive hyperglycemia? The first and the earliest test would be used for monitoring diabetes mellitus was glucosuria, that would be defined as concentration of glucose to be detectable in urine by using relatively insensitive but specific screening tests. These tests mostly are dependent on the action of enzyme such as glucose oxidase, which is incorporated into diagnostic strips. The glucosuria only can be detected when plasma glucose level exceeds the renal threshold, which is exceed the capacity of the tubular reabsorption for glucose reabsorption اللي هي 180 milligram per deciliter or 10 millimole per liter. In very rare conditions, the glomerular filtration rate is reduced and there may be no glucosuria to be detected. In this condition, does not mean the plasma glucose level is below 180 milligram per deciliter. Therefore, the diagnosis of diabetes mellitus cannot be made on the basis of glucosuria. Another measure to monitor diabetic patients is based on measuring blood glucose concentration. Nowadays, this method is applicable for every diabetic patients by the production of the portable glucose testimeters. In this measurement, the color change of the strip can be assessed visually or by using a portable glucose meter and to detect the change in plasma glucose level based on enzymatic activity, mainly on glucose oxidase. Another important measure to monitor diabetic patients is the measurement of glycated hemoglobin, HbA1c. This product is one of the examples of what previously mentioned in this lecture, advanced glycation end product, or it is a result of glycation of proteins, which is specifically in this condition the hemoglobin. This type of reactions is characterized by being non-enzymatic reaction. By non-enzymatic reaction, that means this reaction is not controlled and it would be dependent on the concentration of the reactants. In this condition, the reactants are both the protein and the glucose, and as the plasma glucose level would be increased, the rate of production of this glycated protein would be increased. However, the level of HbA1c would be dependent on the mean plasma glucose concentration during the period of the lifespan of the hemoglobin, which is found in the RBCs. Falsely low values could be found in patients with hematological disorders. In this condition, this time proposed for the hemoglobin to expose plasma glucose level would be reduced. Plasma glucose level would not precisely be reflected by the value of HbA1c measurement. It would not reveal the short-term swing and does not detect hypoglycemic episodes. It gives us a measure of the average plasma glucose level. HbA1c expressed as a percentage of the total blood hemoglobin concentration, and it gives us the assessment of the mean plasma glucose concentration during the preceding 6 to 8 weeks based on the average time of exposure of hemoglobin in the RBCs to the plasma glucose level. The higher the level of glycated hemoglobin reflect the poorer glycemic control by the patient. Also, glycated hemoglobin HbA1c, in addition to its expression by percentage, also it is expressed now as in the SI unit but as millimole per mole of protein or hemoglobin. now, during the treatment of diabetic patients, the goal of therapy, it would be to reach blood HbA1c level below 6.5% in order to reduce the risk of the development of microvascular complications, as we said earlier, because it is related to hyperglycemia. How to relate HbA1c level to the average plasma glucose level? By this formula. Give us the average plasma glucose level in some conditions. The measurement of HbA1c level, which give us an idea about the previous 6 to 8 weeks, which is the average lifespan of the hemoglobin. We need a shorter period to assess average plasma glucose level. The alternative measure of HbA1c, which also could not be dependent on in cases of hemoglobinopathies, as we said earlier, fructosamine is an alternative measure for the glycated proteins to be measured in cases to assess the control of plasma glucose level for a shorter duration of time, because it's dependent on the glycation of plasma albumin, and because of the difference in the lifespan of albumin, which is shorter, about 3 weeks, fructosamine measurement gives us the average plasma glucose level over this period. This measurement of fructosamine is mainly indicated for females having gestational diabetes mellitus in order to assess the control of plasma glucose level and to monitor the treatment with insulin, and if there is any required adjustment for the plasma glucose level based on insulin dosage. All the previously discussed were the complications of diabetes mellitus, considering the chronic complications of diabetes. However, diabetic patients would be also exposed to severe acute complications of diabetes, which are mostly have a metabolic basis. These complications required a rapid response in order to correct the metabolic abnormalities in those patients. Among the important acute complications of diabetes is hypoglycemia, which represent the most serious complications caused mainly by accidental over-administration of any of the treatment used by the patient, such as the insulin or the oral hypoglycemic agents. The patients in this condition have taken his medication and missed to take the meal, or had an excessive exercise after the usual dose of insulin or other oral hypoglycemic agent. This condition is particularly dangerous and if some conditions they take other medications that would lead to misleading symptoms or warning signs such as sweating, dizziness, and headache. During hypoglycemic episodes, if the patient is driving, is considered as a major hazard not only for himself or for other people. Therefore, the patient should always monitor their own blood glucose level closely and always have in their pocket some glucose preparations to avoid the hypoglycemic episodes. Second important acute complication in diabetic patients is diabetic ketoacidosis. This is usually precipitated in diabetics by infection, by stress conditions such as infection, acute myocardial infarction, or even by vomiting. In this condition, diabetic ketoacidosis is mostly presented in type 1 diabetes. In this condition, there is no insulin. When insulin is not present, although it is not able to control plasma glucose level and we have hyperglycemic state, the insulin is able to inhibit lipolysis. In type 1 diabetic patient, because of the lack of insulin, there would be no suppression for the lipolysis, result in increased breakdown of lipids and proteins and enhance of hepatic gluconeogenesis would be further increase hyperglycemia, and besides impairment of glucose entrance into the cells would be increased production in ketone bodies as a result of increased lipolysis. Also, the result of accumulation of ketone bodies would result in disturbance in acid-base balance, causing acidosis, besides the glucosuria as a result of the hyperosmolality associated with hyperglycemia. In this condition, we would have plasma glucose level within the range of 20 to 40 millimole per liter, and even could be developed with euglycemic conditions, ketosis. Hyperglycemia could cause the glucosuria as a result, as we said, due to osmotic diuresis, besides the development of electrolyte imbalance and also increase in the fluid depletion due also to vomiting besides the polyuria. The extracellular hyperosmolality as a result of excessive urination would result in a shift of water outside the cells, causing severe cellular dehydration, and also the loss of water from cerebral cells could result in confusion and coma. The disturbance in the electrolytes results from increased hydrogen ion production with ketones, because these ketone bodies would be buffered by plasma bicarbonate to neutralize this acidity. However, the rate of the production for further bicarbonate would be exceeded and resulted in acidic state. This condition is usually associated with deep signs of respiration, which is known as cosmal respiration, with the odor of acetone in the breath as the classic feature of diabetic ketoacidosis. Besides that, the plasma potassium concentration would be raised as a result of the acidosis. Therefore, the treatment should be started to correct the acidosis and the electrolyte disorders. During controlling or treatment of the hyperglycemia by giving insulin and correct acidosis, there would be a fall in plasma potassium level as a result of entrance of insulin into the cell and increasing also the entrance of potassium intracellularly. Therefore, some cases would be associated with severe hypokalemia and should be replaced by supplementary potassium. The third acute complications of diabetes mellitus is hyperosmolar non-ketotic coma. And this type of complications is mostly detected in type 2 diabetic patients. Which is not associated with ketosis because there is insulin in type 2 diabetes which would act to inhibit lipolysis, and in this condition we have a high elevation in plasma glucose level which may exceed 50 millimole per liter and reach a very high levels of osmolality. And also this condition is associated with increased risk of thrombosis. Lactic acidosis also would be resulted as metabolic complications, and one of the acute complications associated with hyperglycemia in diabetics, which is a result of high anion gap presented as acidosis and could lead to coma in those patients. It may be due to the use of metformin in some conditions, such as high doses taken by elderly patients. Lactic acids produced usually by anaerobic glycolysis, which may be either oxidized to carbon dioxide and water in the citric acid cycle, or could be reconverted back to glucose through the gluconeogenesis process in the liver. Both the citric acid cycle and the gluconeogenesis processes requires oxygen. in cases of anaerobic conditions, only the pathways that would be independent on oxygen or not need oxygen would proceed, such as the glycolysis pathway, which ends, as you know, with the production of lactate or pyruvate. Thus, in cases of lower supply of oxygen, the anaerobic pathway would proceed, leading to the accumulation of pyruvate due to the lack of oxygen. Therefore, the pathways that are dependent on oxygen would be stopped, leading to accumulation of lactate, causing a state of acidity or acidosis. The pathological accumulation of lactate could be the result of overproduction as a result of increased rate of the anaerobic pathway, which is the glycolysis pathway. Also, in case of its metabolism or its utilization is reduced by the impairment of the pathways that are dependent on oxygen when there is hypoxic state, as a result of lowered tissue perfusion, such as in cases of shock, results in this metabolic complication as a result of accumulation of lactate. The hypoxia would increase the lactate level in plasma because the citric acid cycle cannot function anaerobically, and the oxidation of pyruvate or lactate to carbon dioxide and water is impaired, and the combination of impaired gluconeogenesis besides that would increase anaerobic glycolysis, would convert the liver from an organ that consume lactate and hydrogen ion to one that would generate large amounts of lactate. Cases of severe hypoxia can be detected in patients after cardiac arrest, would also result in lactic acidosis. If the diabetic ketoacidosis is associated also with significant volume depletion as a result, as we said earlier, of excessive urination as produced by the osmotic diuresis by hyperglycemia, this would aggravate the acidosis produced by the ketone bodies accumulation. Thanks.